Hello viewers, today I am going to demonstrate you how to do a elbow examination. During this examination I will demonstrate you some common and some uncommon pathologies that happen across the elbow. I am pretty confident that after watching this video you will be able to do a proper elbow examination and will be able to diagnose most common pathologies that happen across the elbow. Examination will start with look or inspection from the front. I'm looking from the front for the attitude. What is the attitude? I'm assessing the alignment. I'm looking for whether if the carrying angle is within normal or abnormal, and I will cover the carrying angle a little bit more detail in a second. I'm also looking for any obvious swelling, any deformity, any previous scars or any sinuses that you do for any of the examination. Examination of the muscle bulk is extremely important. So look for the biceps bulk whether there is any wasting. Look if there is any positive Popeye sign in case of proximal biceps rupture. Look for forearm muscles for any wasting. If somebody has got any pain or somebody has got any neurological disorder, that may manifest itself of wasting of forearm muscles. Don't forget to look the hands. It is examination of the elbow, but always examination of the hand as well, especially looking at the thenar or hypothenar muscles, because if there is involvement of median nerve proximally or ulnar nerve, that can manifest itself distally in form of wasting of thenar or hypothenar muscles. Similarly, you will examine patients from the sides. Sides you are looking for triceps bulk, any obvious wasting, any swelling. If somebody has got an olecranon bursa, you will see a prominent swelling in the back of the elbow. If there is prominence of the triceps and triceps is taut, that could be suggestive of a posterior dislocation of an elbow. You also examine the muscles of the extensor compartment of the forearm for any obvious wasting that can be due to disuse or could be due to involvement of radial or posterior interosseous nerve. Again, don't forget to examine the back for any guttering or wasting of first dorsal interossei or any abduction of the hand which could be due to problems with the ulnar nerve. Again, the last thing you want to do is examination from the back. Now you can see the triceps completely. You have got good view of the posterior aspect of the elbow. You can examine it in an extended position or in flexed position to see if there is any obvious abnormality. See if there is any fullness. The fullness on the lateral aspect, if you see here, there is a hollow. If somebody has got an effusion, you can see fullness here. This can be seen from the side or in the back. Again, you can look for any obvious swelling in form of which could be due to olecranon bursa or prominent triceps in the back. Also from the back, don't forget to look at the forearm and the hand as well. So our look or inspection part is complete when you have looked it from the front, from the side as well as from the back. After this we will move on to palpation. So after the inspection, as I said, I will talk about carry angle. So carry angle is the angle that is formed by a line that you draw across the humerus or across the arm and then across the forearm. And if you see, my hands are not straight, they are at an angle, and this angle that is formed between forearm and the arm is the carry angle. In males it's usually around 5 to 10 degrees, in females it's slightly higher, around 10 to 15 degrees. So the carrying angle is the angle that enables us to carry things. So if I have to carry something, if this hand was straight, I will keep hitting my pelvis. And because of this carrying angle, we are able to carry weight comfortably. Now female, they have got wider pelvis and hence they have got more carrying angle, so that if they have to carry any stuff, they are able to hold it in their hand and walk comfortably without hitting the side of the buttocks or the pelvis. Also, once I have assessed the carrying angle, I always ask the patients to do like this. And this is the best position to assess if somebody has got a cubitus varus, which is a gunstock deformity, or a cubitus valgus deformity. So always ask patients to do this, and in this position you will be able to assess coronal plane deformity in form of cubitus varus as well as cubitus valgus. After you have inspected the patient thoroughly, then we move on to the feel part or the palpation part. In this part, I ask my patients to sit comfortably. You can get their elbows to rest on the table so that they are also comfortable. And then I first palpate or feel the bony part. So when I say bony part, I will first palpate the lateral epicondyle to see if there is any tenderness that could be due to tennis elbow or any obvious injury. At the same time, I will also feel the lateral supracondylar ridge for any tenderness or any irregularity that could be seen in trauma condition if somebody has got a supracondylar fracture. After I have palpated the lateral side, I do palpate the back or the olecranon to see if there is any pain across there. If there is any pain at the tip, that could be suggestive of any trauma there, or if you see a lump there and that is tender, that could be due to olecranon bursa. Lateral aspect, what I do is to rotate to locate the radial head and feel for any tenderness at the radial head. If somebody is tender at the radial head, especially if somebody has fallen from a bike on an outstretched hand, this is a typical area where you will feel the pain, especially on rotation, and that could be due to a radial head fracture. After I have covered the lateral side, I move on to the medial side. So once I have palpated the lateral aspect on the medial side, I feel for any tenderness across the medial epicondyle, which is the site of the common flexor, for any obvious pain. In trauma situation, it could be due to epicondymedial site fracture, or it could be due to golfer's elbow. So it's extremely important that we feel for pain across the medial epicondyle. And the same way, I will also feel across the medial supracondylar ridge for any pain or tenderness. So after you have palpated the bony bits, always palpate the soft tissue as well. Few important things for me are here: biceps tendon. So I palpate across the distal biceps tendon. If somebody has got a biceps rupture, you will not be able to palpate this, or somebody has got biceps tendonitis distally, you will feel pain and tenderness in this area. Also, you can feel the triceps tendon in the back. If somebody has got insertional triceps tendonitis, they will feel pain and discomfort across the back of the elbow. Also, don't forget to feel for ulnar nerve on the inside. Ulnar nerve, feel if there is any thickening or if there is any tenderness or discomfort when you are feeling, and sometimes I just take it through the range of motion just to see if the ulnar nerve is subluxing from the groove or not. So after your palpation or feel part, you go on to the movements. So elbow is pretty straightforward. There are not a lot of movements at elbow. So you're looking for extension. So when somebody is extending, look it from the side as well whether there is any hyperextension. If there is hyperextension, then think about hyperlaxity and do a Beaton score out of 9 to see how somebody is hyperlax. And then you check for flexion. First you do active. So normal flexion and extension is from 0 to around 140 to 150 degree of flexion. And when the second movement that is important is pronation and supination. So to assess pronation and supination, the elbow should be locked on the side. Make sure the patient is not doing this. The elbow is locked to the side, and then pronation and supination. So this is roughly around 80 to 90 degrees either way. The functional range of motion for elbow is around 30 to around 130 degree of flexion and around 45 degree of pronation and 45 degree of supination. So now I will move on to the specific pathologies that you will see as an orthopedic surgeon, and I will tell you how to diagnose it, and we will cover the special tests that you need to know in order to make a diagnosis. Before I move on to the specific pathologies, what I will say is a lot of surgeons will not make some diagnosis in their lifetime, not because the patients, they don't see their patient, it's just that they are not aware of those conditions. So what mind doesn't know, your eyes won't be able to see. One of the common pathologies that I can say is affected by this is called Pronator Syndrome. So Pronator syndrome is a condition which is usually seen in females. Usually they are in their late 40s and 50s. Sometimes they are seen in weightlifters when they do heavy muscle building. The nerve can be compressed and it can cause pain and symptoms. So the typical symptoms of Pronator syndrome are very similar to what we commonly see is called carpal tunnel syndrome. So the patient will complain of pain and paresthesia in around 3.5 fingers. That is the area which is distributed by a median nerve. So it can be very confusing, and unless you are aware that this is a Pronator syndrome, you can think that this could be a carpal tunnel. Now there are certain clinical findings that will help you to differentiate between a Pronator syndrome and between carpal tunnel. So the similarities are that you will have pain and paresthesia in these 3 fingers. So this is common. So what is different? So the first thing is that in Pronator syndrome, the symptoms, they get worse when they are doing pronation and supination activities. That is because the nerve is getting pinched between 2 head of pronator teres, and that can aggravate the symptoms. The night symptoms that are typically present in carpal tunnel, like patient will wake up in the night with numb fingers, are usually absent in Pronator syndrome. Third thing is that if you look deeply in the sensation, if you look at the carpal tunnel patient, then they will have altered sensation in the tip of the index finger. However, if you examine them here, this sensation is usually normal because this is supplied by palmar-cutaneous nerve, which comes around 4 to 5 centimeters before the carpal tunnel, and it doesn't traverse through the carpal tunnel. So if in Pronator syndrome, this area will also have altered sensation. In carpal tunnel, this area will be normal. If you talk about tenal sign, the tenal sign will be positive here at the wrist for carpal tunnel, and it will be positive proximally in Pronator syndrome. Also, if you talk about Phalen's test will be positive in carpal tunnel, but it will be negative in Pronator syndrome. So these are 3 or 4 or 5 clinical findings. If you drill it in detail, you will be able to differentiate whether this patient is having Pronator syndrome or having carpal tunnel. So now I will cover some special tests that we can use to diagnose Pronator syndrome. Pronator syndrome can be due to compression of nerve at multiple sites, as we read in books. So that could be at the bicipital aponeurosis, that could be due to the nerve getting pinched between 2 head of pronator teres, or at the FDS arch. So I'm going to tell you each test for each of them. So let's talk first about if the nerve was compressed at the bicipital aponeurosis. So for that, keep the elbow flexed to around 90 degrees. Make sure your forearm is supinated, and in this position you ask patient to do resistance. If patient is resisting and if it is reproducing symptoms in terms of pins and needles in the hand or discomfort, then that is a positive test that could signify that the nerve is getting pinched at the bicipital aponeurosis. I am choosing to do this examination sitting, but you can do this standing as well. It could be easier. The second common site of compression is between 2 head of the pronator teres. So for this, elbow is completely extended, and then you ask patient to pronate. So patient is pronating. Now this is pinching the nerve between 2 head of pronator teres. If it is reproducing the discomfort and it's making the paresthesia worse in this area, then that is a positive test, and that signifies compression between the 2 head of pronator teres. So the third common site is if the nerve is pinched at the flexor digitorum superficialis arch. So for that test, it's described that what you do is you ask for resisted middle finger flexion. So if you can flex it for me, please. So against resistance, now we are tensing the arch, and in this position, if it is making the patient symptoms worse, that is indication of compression at FDS arch. Now the second pathology that I would like to cover, which again is not commonly diagnosed, is anterior interosseous nerve entrapment. It is again a branch of median nerve, but the symptoms are slightly different. This is usually a pure motor branch because it doesn't supply any muscle. It has got some sensory branches to some small joints, but in essence this is a pure motor branch. So symptoms are slightly different to Pronator syndrome. In this you don't see any sensory symptoms, you don't see any night symptoms, you don't see any paresthesia that you will commonly see in Pronator syndrome. Most of the times, if you have got compression of anterior interosseous nerve, you will see weakness in the muscles that are innervated by this muscle, and that is how you can diagnose it. So the muscles that are supplied by anterior interosseous nerve is of course flexor pollicis longus, of course the two deep the flexors of flexor distal and profundus, and pronator quadratus. So if you have got involvement of anterior interosseous nerve, you will see manifestation in terms of weakness of these muscles. Most of the times, if you have got AIN entrapment, you will see weakness in these three muscles only. However, life is not that easy for an orthopedic surgeon, and as you know, in around 15% of the patients there are some cross connections between median and ulnar nerve, and that is called Martin-Gruber anastomosis. If that happens in patients who are having AIN or anterior interosseous nerve entrapment, you can sometimes see intrinsic weakness that you see in ulnar nerve. So always be aware of Martin-Gruber anastomosis. If you feel there are some intrinsic weakness, however, if you feel on clinical examination this patient is having AIN symptoms, then don't get thrown away by it. It's just because there is some cross innervation and it is due to bilateral due to Martin-Gruber anastomosis. Sometimes you will see this condition or bilateral AIN weakness. If it is bilateral, then always keep Pasterolateral syndrome in mind, and that is a common pathology. Now, how to diagnose it? So I'm going to show you certain tests or signs to look for that will help you in diagnosis. So the first thing that we call is an OK sign. So if a patient can make an O, so if I ask a patient to make an O and the patient can make an O, that tells me that the flexor pollicis longus as well as flexor distal and profundus for index finger is working okay. So that will be a negative. However, if somebody cannot make an O and if the O becomes something like this, so if you see the difference here, the contact between the index finger and the thumb is very little. The skin contact between index finger and thumb is very little. However, if somebody has got weakness, what they will do is they will try to do this. So if you look at this, the area of contact between the two fingers first increases, and also it looks more like a if you see a playboy sign, so this some people call a positive playboy sign as well. So these are some clinical signs that will help you in diagnosis. Of course, if somebody has got found weakness, then you lose the natural cascade of the fingers. If you look at the natural cascade, all my fingers are slightly flexed. However, if there is involvement of AIN, then these fingers will become straight and you will lose the natural cascade of the fingers. That is also a giveaway sign. So the only test that is described in books if somebody wants to check the pronator quadratus weakness is to check elbow in extreme flexion, and I will demonstrate you now. So if somebody has got loss of cascade of the fingers, they can't make an O, that is there are clear signs that suggest that somebody may have an anterior interosseous nerve entrapment. How to assess the weakness of the pronator quadratus? It is quite difficult to assess. So first I would recommend is examine the normal side. To test the strength of pronator quadratus, you bring the elbow in extreme flexion first, then you hold the hand of the patient and ask them to pronate. So Akash is trying to pronate If I find that there is weakness on this hand, then that may suggest that this could be due to AIN entrapment. This is the only way where you can exclude the other pronators and you can isolate pronator quadratus from other pronators of the hand. So the next pathology that I would like to cover is what we call is a posterior interosseous nerve entrapment or radial tunnel syndrome. These are two different entities. However, some people don't believe that there is a clinical entity called radial tunnel syndrome. The only difference between the radial tunnel syndrome and PIN entrapment is in radial tunnel syndrome usually there is no weakness, they just have pain. If somebody is having weakness as well, then that is part and parcel of PIN. So I will focus more on PIN entrapment. It is usually seen in manual laborers, patients who are involved in bodybuilding. Patients describe symptoms usually as pain across the lateral aspect. And the commonest thing that we see in the pain in the lateral aspect is tennis elbow. So it can be commonly confused with tennis elbow, and a lot of patients with PIN entrapment, they are not diagnosed and they are treated for tennis elbow and they don't get any relief. And I'll tell you how to differentiate between these two later on. So the first thing to differentiate between tennis elbow and PIN is that the pain of the tennis elbow is usually at the lateral epicondyle, just around that area. However, pain in the PIN is roughly a couple of inches down. So the pain is more distal in PIN entrapment. Secondly, there is some patient with PIN sometimes will have night symptoms, that they will have more pain and discomfort in the night, which is not usually seen in patients with tennis elbow. If somebody has got a PIN, then there is a weakness of usually finger extension. So if they are extending, even if they are able to extend, the wrist goes into radial deviation because of the weakness of extensor carpi ulnaris. However, if somebody has got a tennis elbow, they can also have got weakness, but that weakness is usually due to pain, and in that condition patients will be able to extend, but the extension will be more central. It won't be going towards one side. So there can be, if there is PIN, they can have marked wasting of the extensor muscles. So these are few things, if you look into your mind, that will help you differentiate between a tennis elbow and a PIN entrapment. Now, how to diagnose a PIN entrapment? As I said before, if there is weakness in the extensor compartment, there is wasting, then that is a giveaway that the patient could have a PIN syndrome. Also, there are certain tests or clinical findings. As I said, if somebody has got a PIN weakness, if they can extend, the wrist will go in radial deviation due to weakness of ECU. Now I will tell you some special tests to diagnose posterior interosseous nerve entrapment. So the first test that I would like you to do when you are suspecting PIN is what we call resisted supination in extension. So your elbow is extended, you grab hold of the patient's hand and ask the patient to supinate. So if the nerve is getting trapped between supinator muscles and if it is reproducing the patient's symptoms, then that is a positive test. The second test that is classically positive in somebody with PIN is what we call is a resisted middle finger extension test. So you ask to extend the patient's middle finger, just extend it for me, Akash. And if it is reproducing patient's pain and symptoms, then that is a positive test. This is classically positive in PIN nerve syndrome. So the last test that I would like you to learn is what we call rule of 9 test. So rule of 9 test was described by Low et al. And that is one test that I would recommend you. So what we do in this test is we draw 9 round areas which are roughly equivalent to $50 coin that was initially described. Akash is quite big because he's a professional bodybuilder, so I made that circle a bit larger. But in essence, what it means, so these 9 circles, how do we do this test? So if you can see, we have divided this proximal forearm muscles, first couple of inches in 9 areas. So this is the lateral part, this is the medial part, and this is the inner or the ulnar part. So if you start pressing on each area here, if you are getting pain and tenderness in this area on the outer aspect, especially in proximally 2, then that is an indicative of a PIN or a radial nerve involvement, which could be suggestive of a PIN nerve syndrome or radial tunnel syndrome. Later on, studies have described that in variations you can have discomfort in this area, but this usually acts as a control. So patients with PIN syndrome typically will have discomfort when you palpate in these 2 areas. Now, coming on to the inner side, if you palpate in this middle area, here, this represents the median nerve. So any pathology that involves median nerve will be positive here. So if any discomfort in this region is due to median nerve. And what do these do? Inner circle. This inner area or the ulnar area is not traversed by any nerve. So these are the controls. So if you palpate here, it should not reproduce any patient symptoms, and this should typically be pain-free. So just to rephrase or to reiterate, the lateral aspect is for the radial nerve, middle is for median nerve, inner is just a control. So this is a rule of 9 test which I would like you to try in your clinical practice. The next pathology that I would like to cover that most of us diagnose commonly in clinic is what we call cubital tunnel syndrome. So this is extremely common nerve entrapment after carpal tunnel. Carpal tunnel is of course the commonest, followed by cubital tunnel syndrome. The patients with cubital tunnel will typically present with pain and paresthesia in ulnar nerve distribution, that is the ulnar 1.5 fingers. So they will report pain, discomfort, paresthesia in this area in early stages, or later on they can have weakness in the muscles that are supplied by the ulnar nerve. Typically they don't have night symptoms like carpal tunnel, but a lot of patients in my experience do have a worsening of pain in the night, especially when they sleep with their elbow in this position on the side affected, and if the elbow is compressed, they report more pain and discomfort. It is a very easy condition to diagnose, and in order to make a diagnosis of cubital tunnel, there are a few clinical signs that are useful, and I will cover one by one. As I said in my inspection, that always examine the hand. So if somebody is showing wasting of hypothenar muscles, if somebody is showing intrinsic wasting like guttering, the wasting of first dorsal interosseous, that is a clear indication that the patient may have a cubital tunnel syndrome. In later stages, if the weakness becomes profound and if it starts to affect the long flexors, then you can have clawing of the hand as well. So look for the hand. If there is any deformity, wasting, then that can help you in your diagnosis that ulnar nerve is affected and it is a case of cubital tunnel. The second thing that I do is to do a Tinel test. So Tinel sign, if you look at the elbow, start proximally and then go distally. Sometimes you will be able to find a typical point. At one point you will find the patient is complaining of a lot of pain, and usually that is the sign, that is the site at which the nerve is compressed. So do a Tinel test, and that is a good clinical test for diagnosis of cubital tunnel syndrome. If you start having weakness of the ulnar nerve, then there are various different tests to assess the weakness of intrinsic, like Fromen's test or weakness of abductor disti minimi. I think I will like to cover that in my hand video when I'm doing the hand examination. So this is a very easy condition to diagnose. Most of the times it requires a surgical intervention in order to cure it. So there are no specialized tests as such for cubital tunnel. I have given you a detailed history and examination and various signs to look for it. If you do a Tinel test, and after Tinel test, what I would recommend you is to do a stretch test of ulnar nerve. So how do you do it? So for stretch test of ulnar nerve, what you do is to flex the elbow completely and then take the patient hand and then dorsiflex. What you are doing is you are stretching the ulnar nerve. So ulnar nerve, the length of the ulnar nerve is maximal at this point, and this exaggerate the compression. And I would recommend you to keep this position for at least a minute. And if this reproduces patient's pain and symptoms, that is a positive test for cubital tunnel syndrome. So after these nerves, I would like to move on to a few ligaments. So I'm going to take you through the test, what we call as a Valgus or Varus stress test, which is to assess the ulnar collateral and the radial collateral ligament of the elbow. So I'm doing this standing up because it's easier to demonstrate. So I'm examining Akash's right elbow. So first of all, you need to unlock the elbow. So you can't examine the ligaments in extended position because our olecranon is locked into trochlea. So unlock it in around 30 degrees. And once you have unlocked it, then use one hand to grab the humerus. And with the other hand, first let's do the valgus stress. So I'm just giving a valgus stress. So now I'm examining the ligament on the inside or the ulnar collateral ligament. So if there is any laxity or if there is no firm point, if it reproduces pain, that is a positive test. Opposite, same way, if we grab hold of the humerus and then we give a Varus stress, now I am testing the radial collateral ligament. On this occasion, I can see a firm point. However, if it reproduces pain, if there is laxity, or if it's opening up and there is no firm point, that is a clear giveaway that there is an issue with the radial collateral ligament. So the next important ligament that I would like to stress on is lateral ulnar collateral ligament, that is LUCL. If this is injured, that causes posterolateral rotatory instability of the elbow. It is a common condition which patients come with. Patient will complain of pain across the elbow and sensation of popping or clicking, especially when they're trying to get up from a chair. That is a clear giveaway of posterolateral instability. This is usually caused by falling on an outstretched hand in which the hand is supinated, there is axial loading, and there is valgus stress. And this is a typical history of fall in which this is commonly injured. However, if in chronic conditions, if there is a pathological cubitus varus or the fracture has healed cubitus varus, there can be slow and steady incompetency of lateral ulnar collateral ligament, but that is an uncommon condition. So how to diagnose it? There are a few clinical tests. So the first test that I would like you to learn for diagnosing this instability is called a pivot shift test, and I will show you how to do this test. So this test is very much like a pivot shift test that I have shown in my knee video. So the patient is lying supine. I have flexed his shoulder at around 90 degrees. We start up with extension. So we start with extension first, and then second thing I do is I supinate the elbow. So extension, supination, and next third thing that we require is the valgus force. So with this hand I am giving a valgus force and gently do this. So it's an art like a pivot shift test. So what you do is you are giving an axial loading, you are supinating, and valgus stress. And what will happen if somebody has got a posterolateral rotatory instability is that you will see a dislocation of the radial head, and you will see the radial head will become prominent on the lateral aspect, and patient will report clicking. After around 40 degree of flexion,
you will notice as you will decrease the supination force, if you let go the supination force and then you flex it, it will relocate itself. So very easy, elbow extended, supinated, valgus force, and just do this. It's just an art, and this way you will get the test. At this 40 degree, this starts with dislocation here, and as you flex more past 40 degrees, it usually reduces. So the second test, which is much easier to perform, that you can do in an OPD setting, is what we call is a chair rise test. In this position, it's very much similar to the pivot shift test that I have shown you. The shoulder is flexed, elbow is flexed, arm is supinated, and then you ask the patient to stand up. Just stand up. So as the patient stands up, if somebody is having rotatory instability, he will have a sensation of popping, and they will report it. So the third test that I would like you to learn is what we call a tabletop relocation test. It's very easy to perform. I do have a narrow table, so I'm asking Akash to do this on a chair. So the arm is towards the edge of the table. This elbow is supinated, and then you can put your hand there and ask the patient to do a push-up and up. So if you hear clicking or if it produces patient symptoms, then that is a positive test. At this moment I was just keeping it gently. However, if you feel that the radial head is popping out, then keep a firm pressure over the radial head and then push it down. And since you are trying to relocate this and then push it up, now you will feel, because of your pressure from the outside, radial head will fail to dislocate, and that is also a positive test. So the next condition that I would like to cover across the elbow is perhaps the commonest, and during the lockdown in the flat I live, I think most housewives have now got this condition which is called tennis elbow, because maids are not coming for the help and they have to do all the cleaning themselves. So there is an increased instance of tennis elbow. So what is tennis elbow? It's usually involves the common extensors, specifically ECRB, but the latest study have also suggested that it could involve ECRL as well as ECU as well. How to diagnose it? It's a very easy condition to diagnose. But one thing that I would like to say is, whenever you are thinking of tennis elbow, always think of PIN as well as radial tunnel as your differential diagnosis. So patient will typically reproduce or will give history of pain across the lateral aspect, which gets aggravated by physical activities. So there are certain tests that will help you in making the diagnosis of this condition, and I will cover them one by one. So the first test that is described to diagnose tennis elbow is what we call a Cozen test. In Cozen test, the elbow is kept at flexion, nicely relaxed on a table, and then you ask the patient to make a fist. So second step is to make a fist. The third step is to pronate. So you keep the arm pronated and then do radial deviation. So ask the patient to do like, and then ask the patient to do resisted extension. So and you keep your hand there. If it reproduces pain across the lateral aspect of the elbow, then that is a positive test for tennis elbow. So next test that I would like to tell you about is the Mills test. The Mills test is a test to do a maximum stretch of the common extensor. So keep your hand there at the elbow. Again, elbow flexed to around 90 degrees. And then pronate the hand, and then palmar flexion of the wrist. And in this position, you slowly bring the hand in extension. And if this reproduces patient's pain and symptom, then that is a positive test. Sometimes in my clinic, all I do is to elbow extend and you stretch it, and if you have pain there, that is a positive test. The last test that I would like to tell you is what we call is a Maudsley's test. This is a test which is meant to specifically test ECRB. So elbow in slight flexion, again forearm in full pronation, and you ask patient to extend the middle finger. And this test is specifically done in order to test the ECRB. And if in this test, when you're doing this, if it's reproducing patient's pain and symptom across the lateral elbow,
and it's reproducing patient symptoms, then that is a positive test for tennis elbow. So the next condition that I would like to cover is golfer's elbow. It's equivalent of extensor tendinitis. This is called medial epicondylitis. This is less common than tennis elbow. It usually involves the common flexor origin, usually pronator teres as well as flexor carpi radialis, but some studies say that involves almost all common flexors except palmaris longus. So the patients will typically complain of pain across the medial side, and this is usually activity related, and it gets worse with gripping activities. So I will show you a test that will help you in making this diagnosis. So this test, I don't know of any name. First thing is just feel across the flexor pronator mass. If that is giving pain and tenderness, looking at the patient face, then that is a positive test. What you do is ask the patient to stand up, we flex the elbow slowly, and now we supinate the elbow, dorsiflex the hand, and you can keep one hand on the inside and then slowly extend it. This way you are stretching the common flexors to its maximum length, and if this reproduces the patient's symptoms, that is a positive test. So elbow flexed, hands on the common flexor, dorsiflexion of the wrist, and then slowly extend it. If this is reproducing patient symptoms, then that is a positive test for golfer's elbow. So the next two conditions that I will cover now will cause snapping across the elbow. So the first condition is called snapping ulnar, and the second condition is called snapping triceps. And these conditions are uncommon but can be easily diagnosed, but can be confused, and they can be sometimes coexistent. So to do a snapping, how do you diagnose a snapping elbow? Snapping elbow involving ulnar. So the first patient will have, if it's happening for a long period of time, they may have ulnar symptoms like I told you in cubital tunnel. And also how to diagnose it. So I put my hand over the ulnar behind the medial epicondyle, and then I take it through range of motion 2 or 3 times. If you feel the ulnar is popping out of its place, it's coming in the front, then that is classical of snapping ulnar. The other common condition which is coexistent or similar to it is what we call a snapping triceps, and the snapping triceps involves the medial head of the triceps. So that's why the snapping of this also occurs over the medial epicondyle, and that can confuse whether it's the nerve or it is the triceps. Same thing, if a nerve is not subluxing, then occasionally either the aberrant head or an extra head of triceps or just a prolonged sheath or triceps can snap across the medial epicondyle. Take it through the range of motion, and this time I'm keeping my hand on the triceps tendon to see if it is subluxing or snapping. And if that is positive, that is, will give you a diagnosis that this is a snapping triceps tendon. So one condition that is common, especially in weightlifters, like what Akash is, when sometimes you see patients with distal biceps tendon rupture. So if somebody has got distal biceps tendon rupture, they will have pain across the biceps tendon. There can be swelling, there can be bruising. If the tendon is completely gone, then you will not feel the tendon here. I can feel the tendon here. If it's absent, then that is a positive test to suggest that the biceps tendon is completely gone. Partial injury to the tendon is extremely common and extremely hard to diagnose. And if one test that I use for biceps is what I call the hook test. So if I can put my finger and hook the biceps tendon, like here, I can hook it. So if I'm able to hook the tendon, see if you can see, I'm able to hook it, the tendon is here, then that is a negative hook test. That means the distal biceps tendon is intact. So you should be able to hook it if it is intact. If you are unable to hook it, then you may ask for an MRI, for a special scan, asking for a FAB sequence in order to confirm the integrity of a biceps tendon.
The other conditions that are involving elbow is usually something like arthritis, which can be inflammatory or non-inflammatory. Patients with arthritis will complain of pain, and they will also complain of loss of restricted range of motion. So somebody has got marked restriction in range of motion, and that is painful, and on examination you can feel bogginess, and if you can feel the osteophytes, and if you ask for an X-ray, that is very easy to diagnose. Occasionally, if you can have osteochondral injuries, that can be hard to diagnose. Patient can complain of occasional clicking if the osteochondral fragment is loose, and during the range of motion, if you do flexion extension, they can complain of occasional locking or sometimes just pain. So you can ask for an X-ray or occasionally MRI to confirm these conditions. So viewers, this was a detailed overview of how I do an elbow examination. I have tried to cover all important pathologies that are involved around elbow. I'm pretty sure that after watching this elbow examination, you will feel more confident in examination, and this will definitely help you in your clinical practice. Please do give a thumbs up, do subscribe to our channel, and do share our channel. Thank you.